we wait a few minutes?
I will have to leave this meeting about 15, 20 minutes a little early. So
Okay.
just a heads up. Thank you.
No, thank you for being here. So today is the last meeting that we have. So we will be talking about some topics and then we'll do some questions at the end. To see, just to chat and see what people think, how they doing their practices, what do they learn. Should I wait or?
I would just go ahead.
Dr. Frieder, you know me by now. I'm a perinatal psychiatrist at Prison for Moms and at Frontier Psychiatry. And let's see, who else wants to introduce themselves? Who wants to start?
Amber Rogers with Mountain Pacific Quality Health, and happy to be here.
Mary Argonis from Mountain Pacific.
What about you, Jacob?
Jacob Wetzel. I'm with Partnership for Children out in Missoula, targeted case management, and we work, have Project Welcome, work with perinatal mothers. So glad to be here.
Right. I'll go how my screen goes. Sarah Beth.
Sure. Hi, everyone. This is Sarah Beth Upson. I am the program officer here at Montana Medicaid that helps to fund the PRISM for Moms program and Meadowlark initiative.
Thank you. Bree.
Hey everybody, Bree McLaurin from Healthy Mothers, Healthy Babies.
Gavin.
Hi, I'm Gavin. I am also with Partnership for Children and I manage Project Welcome, our perinatal wellness program.
Right. Megan. We can't hear you. Oh, now we can hear you. Yeah, now I can hear you. Anyone else that wants to introduce themselves? Okay.
Hey friends, Morton. Yeah, hi, Dr. Frieder. This is Stephanie Morton, Program Manager, Healthy Mothers, Healthy Babies.
Good. Okay. Thank you, Megan. Therapist in private practice in Billings, specializing in perinatal mental health. I read your chat. Okay, so let me share my screen. Okay, so today, can you hear me well? Yeah. So today we are going to talk about infertility, perinatal loss, and I'm going to talk about PMDD and PMS. I'll mention, we will talk about the psychological component of this issue. So infertility. So what is infertility? Infertility refers to the biological inability of a person to contribute to conception. It may also refer to the state of a woman who is unable to carry a pregnancy to full term, or to the inability of a couple to achieve pregnancy after at least 1 year of trying to do so without using any means of birth control. So I thought to start with the definition so we know what we are talking about. So for me, the importance of it is actually, it's obviously the mental health of the couple. And infertility affects more or less 10 to 15% of couples of reproductive age. And in recent years, the number of couples seeking treatment has actually increased a lot. And that has to do with the reason that some people postpone childbearing, some women because of work or because of life circumstances. Also, the development of newer and more successful techniques for infertility, and the awareness that there is available services. So all that makes it that more people are seeking help and seeking treatment for infertility. And for me, the important questions that I get and that I think are important to talk about is that, is there an association between psychiatric illness and infertility? And also, is there an association between psychological impact of infertility and of the prolonged exposure to the treatments of infertility on the mood and well-being? So is there an association between the psychiatric illness and infertility? Is infertility causing any psychological impact? And also the treatments for infertility, do they cause any psychological impact? So what is the psychological impact of infertility? And I'm sure you see it also, but we see this a lot. A lot of emotions come up in these women and in these couples. And there might be anger, depression, anxiety. It can bring up problems in the couple, sexual dysfunction, isolation, stigma, sense of loss, and diminished self-esteem. We see really the behavior of the woman, I see, like really changes. And like sometimes their social circle gets diminished because they don't relate to other people that are pregnant, or they stop relating to people with young children. And so it really, we can see this, I see a lot, the social isolation, the stigma, in particular in certain populations, certain cultural populations, I see it. I work a lot with the Orthodox Jewish population, and that's a big problem, the stigma associated to infertility. And in infertile couples, you see women show higher levels of distress than their male partners. But when the cause of infertility is a male cause, you can see that the distress is really great or increased in the male partner. And infertile couples have a greater sense of loss of identity and have pronounced feelings of defectiveness and incompetence, because for a lot of people, being a parent is part of life, it's part of milestones that you are going to achieve in your life. And when that can't be accomplished, you can lose your sense of identity or feel defective or incompetent. So several studies have found that the incidence of depression in infertile couples presenting for infertility treatment is significantly higher than in fertile controls. So you see here the prevalence of major depressions is in the range of 15 to 54%. They also see that anxiety is higher in infertile couples than compared to the general population, with between 8 to 28% of infertile couples reporting clinical significant anxiety. So this is important to keep in mind. And how depression, so we say, you know, infertility can cause anxiety, can cause depression, anger, isolation, a lot of things, but can depression cause infertility? Can that directly affect infertility? And it seems that that could be, there are some studies that suggest that depression could elevate prolactin levels and with that make it difficult to get pregnant, disrupt the hypothalamic pituitary adrenal axis and thyroid dysfunction, and all this can make it hard to get pregnant. It can also bring changes in immune function that usually is associated with stress and depression, and that can affect the reproductive function. And the process of assisted reproduction is also, the treatment itself, it's also associated with increased levels of anxiety, depression, and stress. And with more failed IVF trials, there is more depression. And many dropouts in infertility treatment have to do with psychological factors. It's so complex, this situation. What I see a lot is not just the treatment, the assisted reproduction treatment that is very draining and hard for women and can create symptoms. Is the effect of the medications per se that are used for it. And also like what I'm seeing now is like also like, you know, the insurance issues, like will the insurance cover for it? Will it not? How much the woman will need to pay? It's a financial burden too for some women. So most studies support the theory that distress is associated with lower
Mariela?
Yes.
Did you see Megan's question about speaking to the hormonal treatments associated with fertility treatments and how it impacts mood?
I don't see any questions.
Yeah. Yeah, I think that was a good one. It's in the chat. So Megan
Oh,
said,
okay, could you speak to how the hormonal treatment associated with fertility treatment impacts mood? Yeah, we'll talk about that. I think it's
right
in
on.
my
Thank you.
next. I don't know if it's in my slide, but I'll talk about it if it's not. So let's see. What am I saying? Can you hear me? Okay. So most studies support the theory that distress is associated with lower pregnancy rates among women pursuing infertility treatment. And there are some studies about cognitive behavioral therapy and support groups, and they see that these groups decrease stress and mood symptoms, and with that, they increase fertility rates, which is so good, you know, to know that actually improving the mental health of the woman can really increase fertility rates. So like here in a cohort of 184 women, viable pregnancy rates were 55% for the cognitive behavioral group, 54% for the support group, and 20% for the control. So this is really a difference. And there is no data to suggest that commonly used antidepressants negatively affect fertility. So I'll talk a little bit more about that. There are very few studies about antidepressants and their effect on fertility per se. There is more, I think there are 3 or 4 articles about the effect of antidepressants on the male part of the fertility, with 2 of them suggesting that some antidepressants might affect fertility and the other 2 saying no. So we still have very little information about it, like it's not enough to draw conclusions, but we know that women that do better and men that do better emotionally have higher chances of conceiving and having a viable pregnancy. So that's something that is still in study. What is the effect of antidepressants on fertility in male fertility? So I wanted to put this slide here because in terms of antidepressants, there is a study that a very big study that actually they followed 1 million, more than 1 million women, and they gave the choice to the women to stop the medication before conceiving or continuing it in the first trimester. And they saw that there was an increased risk of miscarriage in the patients that were depressed and not with antidepressants. So that I think is reassuring in terms of treatment, because a lot of women are concerned about taking the medication and then conceiving and then losing the pregnancy. So that's a very reassuring study. And what the study suggested that was important is that the depression per se can cause miscarriages more than the antidepressants. But there is a lot of problem with studies about reporting, like some women, because of cultural issues, will not say they had a miscarriage. They won't say they had an abortion, so they might say it was a miscarriage. Few studies control for depression and other confounding factors like age. So it's difficult to interpret data in this sense. But overall, the well-done studies don't suggest that there is a risk of pregnancy loss with antidepressants. So before I go to pregnancy loss, let me answer the question. So clomiphene, that is one of the medications used for assisted reproduction, seem to have effects on mood. So that's a problem, and that's something that I see a lot, and I try to help women with, is that when they are doing the treatment with the hormones that they use, they can have emotional symptoms, mood symptoms, and it has to do with two factors. One, some women have a history of having mood changes with hormonal treatments like contraceptives, and some women really are affected by the medications that are used to stimulate ovulation and to maintain, like the different medications that are used during the cycle, the medicated cycle that is used to retrieve the embryo, so you can then do the IVF. So it's a problem, it's really a problem, because we see irritability, depression, anxiety, and insomnia sometimes. So it's not just the going through infertility, going through the treatment, not knowing if you're going to get pregnant, having to inject yourself every day, going for the monitoring at the center, and also the effects of the hormones in your body. I just mentioned the psychological effect, but there is also the bloating. Some women have headaches, it really can affect them. But it's very hard to predict who will be affected, unless I know. Some women come and tell me, I really have a very difficult history of how the hormones have an impact on me, But some women know, and it's hard to predict who will be affected. So in terms of pregnancy loss, we don't really screen for depression or anxiety after pregnancy loss. And many women actually don't follow up after they lose a pregnancy. But it is estimated that about 20% of all pregnancies end in miscarriage, and another 14% in termination. And the data in terms of mental health is mixed, but recent studies show that levels of depression, anxiety, and stress are increased following both miscarriages and termination. My experience is that it has a lot to do with the decision of the woman, how she made the decision, and what are her reasons to do it. Was she coerced into it? Was somebody else that really wanted her to have the abortion? Did she want the pregnancy? So I think there are a lot of factors that can have an impact on the mental health of the woman and making her more prone to be depressed, anxious, and stressed after a miscarriage and termination, and also the hormonal changes for women that are more sensitive to hormonal changes. Any questions? Any comments about this? I was checking if there was any other question written. So one thing I wanted to talk about is about PMS and PMDD, because I see it a lot and it's very prevalent. And I was wondering also if you see it in your practice, but at least 90% of women with a regular menstrual cycle will report unpleasant physical or psychological symptoms premenstrual. So that's what we call PMS, premenstrual syndrome. It doesn't affect your daily life. You have some symptoms, but it doesn't affect your functioning. But then there is the PMDD, premenstrual dysphoric disorder. And that really can cause a disruption in the woman's life. But that's less of the population. So the prevalence is 3 to 8% of the patients that we see. So what are the symptoms? There are psychological symptoms, physical symptoms, and behavioral symptoms. And as you see here, there's a long list of symptoms that you can have. So anger, anxiety, depression, irritability, sense of feeling overwhelmed, sensitivity to rejection, social withdrawal, physical symptoms, a lot: bloating, appetite changes, breast tenderness, headaches, lethargy, muscle aches or joint pain, sleep changes, swelling of extremities, and then behavioral symptoms that kind of go with the psychological ones: fatigue, forgetfulness, poor concentration. So it's usually, PMDD is usually associated with a lot of mood reactivity and irritability. And usually what you see the symptoms 2 weeks before the menses. And typically they resolve once the menses start. And to meet criteria for this, it needs to affect in some level your functioning. So either social, occupational, like school, work, relationships. But it's very prominent how it affects the interpersonal functioning. And usually it starts in the 20s, but symptoms can get worse over time. And I see it a lot after pregnancies, actually, when they resume their period. Women can have like prominent symptoms that they didn't have before. And the major risk factors for it is personal history of a mood or anxiety disorder, family history of premenstrual mood dysregulation, stress, and age in the late 20s to mid 30s. So one important thing is to differentiate, is it really PMDD or is it a mood exacerbation that happens in a mood disorder premenstrually? So that can happen. Women with bipolar disorder, depression, even anxiety can have more symptoms the 2 weeks prior to menses. And that's not really PMDD, that's an exacerbation of their symptoms, if they have symptoms outside of that 2 weeks. So to make the diagnosis of PMDD, it needs to be just during the luteal phase, during the 2 weeks prior to the menses. So the best way to confirm the diagnosis is by prospective daily charting of symptoms. And we say that at least you need 3 months, consecutive months. And usually, and there are some rating scales that you can use, and there are some apps that you can find online, to monitor your mood. I tell women just to get a calendar and write even a word of how their mood was that day, and then show it to me and write when they got their period. And then we can go over it and see the relationship. And initially they thought they didn't know why it was happening. They thought maybe these women have different levels of hormones, but now we know that that's actually not the case. That actually what happened is that these women have a higher sensitivity to the normal variations of hormones that happens during the menstrual cycle. Also, recent data suggests that women with premenstrual mood disorder have abnormal serotonin neurotransmission. And this is important when we talk about treatment. And this is along with a lower density of serotonin transporter receptors. And this is thought to be associated with symptoms such as irritability, depressed mood, and carbohydrate cravings. So what is the treatment? First of all, is the diagnosis. You need to do monthly mood charting to make sure that this is the diagnosis. Then lifestyle modifications are very helpful. So eliminate caffeine, sugar, sodium during those 2 weeks are very important. Decrease alcohol and nicotine. Make sure you are sleeping well, make sure you are exercising, all that is helpful. There is literature that supports using calcium to decrease the symptoms, both physical and emotional, of PMS. Also B6 seems to have a good effect. There is less supportive data about magnesium and vitamin E, but calcium is really one that I suggest to all women because it really seems to help. And then there are some some alternative treatments that you can use, like chasteberry seems to be very helpful for the somatic symptoms of PMS. Ginkgo biloba also helps mostly with the physical symptoms. They did a study and they saw that the cognitive behavioral therapy was as effective as fluoxetine, but fluoxetine was in a low dose. Usually for PMDD, you have a response with low doses of medication. And what we really know is that there is a real good effect of the antidepressants, the SSRIs, in reducing both the emotional and the physical symptoms. And what is interesting is that for depression or anxiety, you need to take the medication, the SSRI, for 3 to 4 weeks before it starts working. However, for PMDD, they work immediately. So there is a possibility to take it in different ways, so you can take it continuously every day of the month. You can decide just to take it during the luteal phase. And then what I do, this is mostly I do for women with a mood disorder that have a exacerbation of their symptoms in the luteal phase, is that I tell them to increase the dose those 2 weeks before their menses. And that seems to help tremendously. Then oral contraceptives are helpful, mostly the ones that have drospirenone, that is one kind of progestin, and it's chemically related to spironolactone, and we also use it, that's a diuretic that we also use for fluid retention in women with premenstrual symptoms, but the oral contraceptives that have drospirenone seem to have a good effect on PMDD. Then for some women that all this is not enough, they need higher interventions, levels of interventions like leuprolide or danazol. That basically what you are doing is you are putting a woman into menopause, like chemical menopause. And that's how you treat the symptoms. And then it's described in the literature, women that actually have surgery, hysterectomy and bilateral salpingo-oophorectomy to relieve the symptoms of PMDD. So I'm sure that for sure is the more severe cases. So any questions about this?
There was a question in the chat about if there's been any evidence of evening primrose oil with PMDD or PMS.
So there is some data about it. It's not so consistent like with chasteberry, like it seems to be stronger for chasteberry, but there is some data about primrose oil. Yeah. Let's see. So what else? Let's see. So now we are going to go to do the questions that I have prepared for today. But any questions before about this? No? Any comments? Do you see women with PMDD? A lot. Like I see it a lot. And not just PMDD, but I see women with mental illness that have exacerbations prior to their menses.
Would you say you're seeing that more often? I think it seems like there's more hormonal disruptions, or maybe it's just working with this population more.
I think it's working with this population, and I think that we are more aware of it, so we ask more about it, and women are more aware of it, so they can report it more. I don't know, that's a good question. I don't know if compared to before, maybe.
No, go ahead. I was just going to ask, do you feel like most OBs or most mental health providers, psychiatrists are treating it kind of with the treatment recommendations, or do most kind of think this is a bunch of hokey pokey still?
No, I think what I see is that OBs are treating it, Yeah, less psychiatrists, but I see more OBs know about it and treat it with contraceptives, or low dose SSRI. So here I have some questions. So let's see. Yeah, it seems that people know about perinatal mood and anxiety disorders nationally. Then the second question. So during COVID, it seems that actually we see it more, and we see it 1 in 5. That's what I found in the literature. So we see more perinatal mood and anxiety disorders, and which makes sense. I'm sure people that work in this field and see women that went through pregnancy and delivery during COVID, see how stressed it was for them. So can we see, I don't know how to do, can we see the next question? Should I? Let's see. I don't see, do you see the next question? Oh, here it is. Yeah. So it seems we are all on the same page, that we screen for PMADs. And yeah, I use the EPDS. It's really easy and it's validated in pregnancy and postpartum. And I like it because it also has questions about anxiety that are helpful, gives you a hint that maybe there is an anxiety disorder. They ask about suicidality, which is a red flag. And also it leaves outside the questions about physiological questions, like about sleep or appetite, that can be affected in pregnancy and make things more like not so clear. Is it the pregnancy? Is it the depression? What is it, But yes, I think the EPDS is a great tool to use. It's self-administered and it's fast. Can we see the next question? So this is something that I'm working on, like to increase awareness about this. I think for anxiety, we all know, that we need to screen for it. And I'm sure, I don't know, what do you do? Do you use a screening tool or you just ask questions about anxiety?
So I typically just have a conversation and ask the questions, but on any new intake I do, I have them do both the GAD and the PHQ-9. And so, yeah, I have them do it, but then we have a conversation based on that.
Yeah, that makes sense. And what about bipolar disorder? Do people screen for it?
I do. I use the mood disorder questionnaire for that as well. But I mean, and again, and I do these screenings, but I feel like I get more information from just a conversation, and using that screening tool just as like a guide to the conversation.
I agree. I think that's why all these are screening tools and not diagnostics, like they help to start the conversation. They help to then start with the real questioning to see if there is a diagnosis or not. Because also what I see even with the EPDS is that sometimes women answer everything no, and then when you have the conversation, you really notice they are depressed or anxious, like, so for some women it's hard to open up or to say how they really feel or complete a questionnaire. So it's a way of starting a conversation, I think.
We,
And
with our perinatal clients, we use the perinatal mental health discussion tool from Postpartum Support International.
Okay.
And that has seemed to be like a great tool. Like we've done it. We've just included the form in an intake packet before, and that can really help inform like discussions. But then also just kind of going through it with clients and just kind of making sure that you've got bases covered in a conversational kind of way has been very valuable. I mean, it doesn't like hit on bipolar specifically, but I feel like it does a great job of just kind of checking the boxes for a lot of other PMADs that folks might be going through.
What does it include, more or less?
Yeah, so for example, the first section says, I have been experiencing the following symptoms, and there's a whole bunch of options you could check. The first one's feeling depressed or void of feeling. One of them is feeling an urge to repeat certain behaviors to reduce anxiety. Another one's scary and unwanted thoughts. And then another box is thoughts of harming yourself or the baby. And
I see.
Yeah. So I feel like it really does a good job of in a very non-judgmental way, like introduce like screening for like postpartum psychosis and things like that too.
That's great. Yeah. I think it's important to have some kind of guidance, or at least at the beginning, until you have everything in your head. But it's a very particular way of interviewing patients. Like you have to ask certain questions that you might not ask or ask differently in other populations. So it's important to have some guidance. Mm-hmm. Can we see the next question?
And Dr. Frieder, I just put a link to that discussion tool in the chat if you wanted to look at it. It's a really brief, easy, like one-pager PDF.
Okay, perfect. Thank you.
Yeah, thanks, Megan.
So what do you think about these questions? Which antidepressant is contraindicated in pregnancy? So this is a tricky question, like just because there is so much controversy about Paxil, and there are a lot of thoughts about it. And initially they said it could be it should be contraindicated, but actually the better done studies show that it doesn't really increase risk of malformations. And none of the antidepressants that we have are contraindicated in pregnancy. They're actually, it's a risk benefit. You always need to have a risk benefit discussion, and see what is more risky, if they're depression or the antidepressant. Yes, the antidepressant can have some effects on the baby, but nothing that will make them contraindicated, And when you put it in a balance with the depression or the anxiety that the woman has, you see what is more risky. And usually, so far, what I see is that the mental health issues are more risky than the medications, than this particular medication. And then the PTSD question, PTSD can have negative obstetrical outcomes, true or false? Yes, it's true. We agree that women with PTSD, they can have preterm delivery, low birth weight, they can have even like for them negative effects, you know, like suicidality, substance abuse, and that can have a negative effect. They can have, when the baby is born, the baby can have difficulty adjusting, difficulty eating, difficulty sleeping, and it has to be taken, like it has to be evaluated and taken care of because it can have negative effects. What about the next one? So this is about substance abuse. In Montana, if when somebody is using drugs, diagnosed or suspected, do you need to report it or not? And do you screen for SUD? Yeah, that's true. So different states have different policies of how to treat women with substance abuse, what to do with them. But in Montana in particular, you're supposed to report. And screening for substance abuse is so important, more in a state like Montana, I see so much, you know, that not because to be judgmental or to be punitive, but to help these women, you know, because pregnancy is a time that women want to be better and want to get better. So it's a good window of opportunity to use to help them stop using drugs and alcohol or whatever they are using. The idea will be to actually help them sustain that later on, not just during pregnancy, but some women do it for their babies and then relapse, and some of them are able to maintain that later on. Any other questions? We have two more, no? So yes, both of them are, oh, not, I'm sorry, I was going to answer and not everybody answered the question. So yeah, methadone saves lives, you know, it's really important to know that because women don't use opioids when they are supposedly, they are not using opioids when they are getting methadone, and that helps them be away from negative behaviors and also helps not to have the ups and downs of opioid use in their body that can cause first overdoses, but also can affect the baby. So clearly it saves lives in pregnancy. And fetal alcohol spectrum disorder are the most common and preventable cause of intellectual disability in the US, which is important to know because it can be prevented. So, and there's no real level of alcohol that we can say it's safe to use in pregnancy. So it's important to look for it. Okay, so those are my questions. So any questions, any comments, any feedback?
I did just want to highlight a chat that Naz stated, and I don't see it now right off the top of my head, about just having a usually comes in with the intake conversation on the intake screening form about bipolar. And, you know, so just wanted to highlight that.
Yes, it's so important to screen for bipolar because it will change the way you treat patients. And not just the way you treat, it's also what you have in mind, what can be their prognosis, you know, how the pregnancy can go and how the postpartum can go. We know that women with bipolar disorder are at an increased risk of a mood episode during pregnancy, more if they stop their medications, but even if they take their medication, they're at an increased risk, which it's a reason that why we have to keep an eye on them. But then they are also at an increased risk of postpartum depression and postpartum psychosis. So, and that can be very serious. So we need to make the diagnosis. And what also why we make the diagnosis is that if you give an antidepressant to a woman that has bipolar disorder and you are thinking that it's just depression and you give them an antidepressant, you can make them manic with the antidepressant. They can switch into mania. So, and that can have detrimental effects. So we want to make the diagnosis very well. But I wanted to talk a little bit more about infertility, you know, because it's so important and we see it so much and women suffer so much from it. I have a patient now who has been doing IUIs actually to get pregnant, and she did like 5, I think, and she got pregnant once, had a miscarriage, but she's in her 40s. She's 40 now. And when I was saying about the insurance, I was thinking about her in particular because insurances don't, some insurances don't pay for IVF after a certain age, you know? And then the rate of success of IUI is much less, you know? And then all the treatment, all the medical visits, the IUI, the IVF, the medications, everything has a price and everything, the bills pile. So it's not just that you are stressed because you are trying to get pregnant and that's something that you want and you're not achieving. It's also the cost of it, the financial burden for patients. And that can bring up psychological problems. But what I wanted to say also that I didn't mention before, but I see it a lot, is that women that succeed having a pregnancy after infertility, I see also PMAD after it, you know, like you really see women like, okay, now what, you know, I put all this energy in getting pregnant, I left aside other things, I didn't pay attention to my relationship, I didn't pay attention to other things, and now I'm pregnant and what, you know? So you see an increased risk of PMAD after getting pregnant, after infertility. And I'm not sure it's just that what I mentioned, but I think it's important to screen these women because that can happen. Maybe it's not what they expected, you know, maybe they have their own fantasies of how it will be. But I had patients like with panic attacks after getting pregnant, patients asking me, please, I need to stop this pregnancy because of how I feel emotionally after they really, really try to get pregnant, you know? So it's something to keep in mind and keep an eye and screen these women. Any thoughts?
I'll just kind of deepen a little bit that the changes from, struggling with infertility and then becoming pregnant and what changes. It's also a huge change in social supports. If you start to look, lots of women who are, or families that are struggling with infertility, there's really strong online resources and groups, and you have an identity. You create that identity in that space. And if that's been a long-term struggle, that shift into, moving away from this piece into a different, I think that those relationships that have been their support systems, whether that's from a provider standpoint or from a social support friend and peer standpoint, are super, that's interesting to me too. And
Yeah, I
you know,
agree.
I don't have any evidence that that's what like increased that risk, but you are, you know, it kind of parallels some other shifts when folks are going from, you know, that in that first pregnancy of changing identity.
I totally agree. You know, I see it a lot, like women that have been in infertility groups and now they are not there anymore, you know, and they had the support there, and where are they going to get that support now? And totally, I totally agree with that. What else? Any questions? Any
I just
comments?
have just a thought and just remembering like the PTSD, you know, aspect of it all. And I think for some of the folks that are not maybe like prenatal care providers, but are a community-based service, and you know, there's resistance and things like that, just to never forget there might be some sort of a trauma fear component to, you know, refusing or avoiding versus not actually needing the help. And then I just remember like, so, I mean, you mentioned it, but you know, my sister had a loss and lots of infertility. And then when she finally did have the baby, oh my gosh, I was weighing that baby constantly because she was so scared that the baby wasn't hungry or feeding enough and this and that. And it was interesting because she, you know, welcomed a home visit of a nurse, and the nurse just had a tiny bit of her own anxiety in the situation, probably that she just picked up on because she was just so anxious, and just, you know, and then she couldn't even handle that. And so I just thought it was just like, that was just a lot for her. And I just think that those of us that are doing direct care, that's not just like going to the doctor and just remembering like how the PTSD can really get like cycled in, or even like the smell of the laundry detergents or like things like that we wouldn't always think about. So just remembering to like where the support is, you know, should be offered in many places, like outside of clinical settings or places where they might have had their loss, or just thinking about location and place-based anxiety. It's just, I think that's just something that we forget sometimes more.
Yeah, I agree.
So tender.
And then what you mentioned about after pregnancy, after a loss, you know, it's so important to keep an eye because there is a lot of PTSD, anxiety about the current pregnancy when the date of the loss is approached, you know, like those pregnancies I see with a lot of anxiety. And then when the baby is born, like the postpartum too, you know.
Yeah. And then I just also think about like those of us that are interested in like infant parent interaction, promoting, you know, healthy bonding and attachment development, is like, you know, how much of that, like that next baby is going to save you kind of mentality, and how much pressure might be put on that live child to like fill an old hole. And oh boy, just how to talk moms through that awareness, I think is a challenge, but important as well.
Yeah, I agree. Yeah.
One thought that I had today to bring up is just the use of language, and how when we talk about infertility, just the word infertility sounds so final and hopeless. And so my wife and I, we've actually had fertility challenges quite a bit over the last several years. And just that phrase itself, like fertility challenges, is so much more preferred and just like friendly and like surmountable than just saying, oh, we're struggling with infertility, you know, just because that I feel like there's a big difference there from kind of that patient perspective or client perspective. And so just thinking about fertility challenges. And then I also wanted to mention just kind of like the male perspective, and just like when working with couples, that, I mean, it's, as we all know, it's not always, you know, half the time it's going to probably be the female who's having the biological challenges. And I mean, and I'm still speaking in the gender binary, I just want to acknowledge that, but another time, a lot of the time too, it's going to be the male who's going to be having the biological issue, and just being able to hold our male patients and clients and just like that in that space, and like thinking about how essentially like a threat to their masculinity it is to not be able to conceive, and just thinking and just thinking about holding that space for them. So
yeah, totally agree with that. I think it's so important, you know, like in all these infertility, but also, you know, like, you know, all these PMADs and during pregnancy and postpartum, to always keep in mind the partner, and it can be like a male or a female partner, you know, that also are going through things, you know. And yeah, because we didn't even touch all the fertility issues with partners of the same sex, you know, like I have a lot of patients that are from the same sex couples, and that are using fertility treatments to get pregnant, and that also is very stressful and can create a lot of can have a psychological impact, you know. So it's like holding a space for the partner, and if the partner has something to do with the fertility challenge, as you said, most important, you know, to hold the space for them. So I totally agree with that. That's so important.
Thanks for sharing, Gavin.
Yeah.
Yeah.
You know, I'm very supportive of my patients when they are going through fertility treatments, and in terms of like making it easier for them, because there is so much pressure in so many levels, you know, and it's so hard to go through the treatments, and you need to perform at work, you need to perform in life, you know, and at the same time, you are going through these injections or this uncertainty and monitoring. So I had a few cases that I actually gave them a leave during that time, you know, to decrease the pressure on them, and so they can really feel less stressed, and we know that stress can decrease fertility rates, you know. So yeah, I had some patients that or work with them to figure out how to decrease the stress level, you know, like if they need to work less hours, or there is something that they are doing that they can not do now, or they need to improve their sleep, you know, or their eating habits, or like, I think it's so important and validating at the same time to do that.
I think one more piece that comes to mind for me when I think about it is just being really open to a wide array of different spiritual ways to tap into, you know, whatever belief system you have, and just as caregivers being really open-minded to kind of what people need to heal, especially if it's outside of the realm of like what we commonly hear about. But I think, you know, like everybody finds their path to like peace with it in a different way, and just being really kind of open and realize there's a lot of kind of, you know, it's that birth, life, death circle. It's big stuff.
Yeah, that's true.
Yeah.
Yeah. And that's also takes us into the cultures, you know, and how cultures affect.
And I don't think we don't have a lot of necessary dialogue and narrative going around about like what are those kind of nuanced practices. And, you know, I just remember, I can't even remember what the goddess was, but my cousin who was trying so hard to get pregnant, you know, she had somebody send her this goddess statue, and it was really important to her. And we all had to give recognition to the, you know, because she really needed that. That was her. And I just thought that's really important to remember.
Yeah.
Mhm.
So thank you for being here. It was so nice.
Thanks for all of your echoes. It's been wonderful to have your teaching.
Yes, thank
Looking
you,
forward to the
Dr.
next
Freer.
round.
Yeah, I really enjoyed the conversation. So
Thank you, Dr. Frieder. I echo that. It's been great.
thank you. Thank you.
You will.
All right,
Okay.
bye.
Bye.
Thank you, everyone.
Yeah.